Andate a casa, non c'è nulla da fare. 25 anni fa, una diagnosi di distrofia muscolare di Duchenne.
È vero che i miei muscoli diventano sempre più deboli.
Una patologia degenerativa rara che colpisce i muscoli. Ma c'è chi non si arrende e fonda Parent Project. Intanto il mondo cambia e anche Parent Project cambia un po' il mondo.
Ringrazio Parent Project e le
Nuovo approccio terapeutico.
Dall'ultimo anno finanziato da Parent Project.
Parent Project che ha
Circa 8 anni della prima volta che
in maniera
I pazienti oggi hanno un futuro da immaginare, degli obiettivi da raggiungere e dei traguardi da conquistare. Oggi, anche con la Duchenne puoi diventare ciò che vuoi. Come
Luca Buccella, che ringrazio per essere con noi.
Correre insieme e fin dei conti è una sfida già vinta.
I'm here to tell the future is there.
Jacopo,
Alla Duchenne.
Matteo, Lorenzo, Luca, Samuele, Francesco e come tanti altri ragazzi che vivono una vita piena. Ma questo non basta, non c'è ancora una cura e tanti sono gli ostacoli da superare e le strade da aprire.
Tutti insieme
Abbiamo formato una grande famiglia.
Scrivi i prossimi 25 anni di storia insieme a noi.
Buongiorno a tutti.
Good morning, everybody. This is the fourth day of our 18th International Conference. We started on Wednesday afternoon from our studios in Via de' Francisci in Rome. We have transformed our office into a real TV studio. And this is something that, of course, is extremely emotional, and we are having great fun. First of all, a big hug to all the speakers who are here with us and all the participants, both from Italy and from abroad. At present, there are also people that are online from the States, where, of course, it is night, so special thanks to them. And today and tomorrow we'll have full days. You just have a couple of hours off over lunchtime, and that's it. And before telling you about the program, I'd like to say that both today and tomorrow, all the sessions will be translated both into English and Italian, and that the translation is available all the time. So you have just to click on the interpreting channel, either English or Italian. We ask all chairmen and all rapporteurs to speak slowly so as to enable our fantastic interpreters to work as easily as possible so that everyone can follow the conference. Before telling you about the program and giving the floor to Ilaria and Gloria, but first I'd like to welcome you on behalf of the Executive Council. On Wednesday, we opened with the welcome by Luca Genovesi, our national president. He'll be with us tomorrow. Then we have our vice president, and tomorrow we'll also see Filippo Buccella, who needs no introduction, being the founder of our organization. But I'd like to thank all the other parents of the executive committee. Sara Caponi from Liguria, she's the mother of Giovanni. Giovanni's 9 years of age, and Ezio as well. He's a historical father of our association. He is again from the executive committee in Syracuse. and the father of Marco, who is 18. Yesterday, Marco Magnano, I mean, yesterday was his birthday, and so best wishes. And then Marco Arlecchino is one of our historical dads. His son is 33. And then Gerardo Laurenzano is another member of our executive committee, and is the father of Antonio, who is 18 and he's a BMD patient. And then Paolo De Leo, who is a new member of our executive council, and he was elected at the members assembly last October, and he's the father of Emanuele. Emanuele will be 9 tomorrow, so we seize this opportunity to wish him a happy birthday. And also Gianni Bontempi, who is one of the historical members of our association, and he is a volunteer of the association. He has been following Parent Project for many years, and he has been organizing events for fundraising for many years. Together with the Executive Council, I wish to welcome you also on behalf of all the parents who are delegates. I mean, Parent Project is really managed by parents and patients. Our local delegates have always been online, and I wish to thank them for their outstanding contribution for what they've been doing, I mean, to bring all the members of our association information and also well-being, thanks to the idea of sharing all this information. Another body is what we call the Consulta of Patients, is a sort of advisory board, and it is this body is made up of the boys, I mean, of the patients from 16 years upwards. And then I'd like to thank again all staff members of our association. You have seen some of them. Well, you keep seeing me again and again, as well as our biologists and people from the scientific office and all those who work at the listening center. We had Ruggero on the first day who introduced the activity of fundraising, but there are also many other people who are online from home, but they're not only following from home, but they give an essential contribution for the organization of this event, as well as the other activities of Parent Project. We cannot mention all their names, but we'll do it between today and tomorrow. And I'd like to underline that what we can do, what we actually do, is the result of teamwork. And that is why I'd like to ask all of you two things. Well, first of all, downloading and also make available all the material we produce. We produce a lot of material now. The service will share the page of the website with all the materials that have been used for the different sessions, or that will used also for other sessions. We have also the brochure of for women, and we prepared it with the contribution of Professor Ferlini. But I mean, we have been producing quite a lot of material thanks to the work of the whole staff. Download them, read them, and make them known to all the families, but also to clinicians, I mean, to all stakeholders. Another aspect I'd like to mention, and and you'll find it on Zoom, and we'll put it on the chat. So there is also the questionnaire linked to the assessment of the impact that the regenerating project has had on families. We see Gloria now will introduce, well, yes, they have decided to have her on the screen and all with this pink in the background. In fact, she hates pink, but never mind. And so please fill in the questionnaire, and our video, the video with which we start all the sessions, and I hope you liked it, and the title of which is Write the Next 25 Years of History Together with Us. Since today, this year, we celebrate our 25th anniversary, and the project is called Regenerate and was funded by the Italian Ministry. And all the families involved in all the activities we carried out this year, meetings, Zoom meetings, groups among families, support activities, I mean, all these things must be assessed by you through this questionnaire, because we must demonstrate also what type of impact these activities have had on the families. So thank you for filling in the questionnaire. And I'd like to thank Francesca Bontempi and Fabiana Boccia. They are at home, but they are the people who follow the projects, who help us find these funds, and these funds are essential to make our activity go on. And now we start this morning session here at the table of our studio. We have here Ilaria Zito. Ilaria Zito is one of the 3 biologists of our scientific office. She has been working with us since 2018. She's also a writer, and she deals with all the activities of the Scientific Bureau, more specifically of the patient registrar and registry, sorry. And together with her, the other chairperson is there. Well, from home, Gloria Antonini is here. She's one of the 3 biologists of our scientific office. Gloria told me that one of her passions is, well, making science get down from the ivory tower, and so that it can reach all citizens. And that is why when we had a look at her CV, she has a master in science for journalism, and one of the activities, together with many others, she also manages all the researchers and all the projects funded by Parent Project. She tries to build forms, let's say, really templates for science communication, so that information can truly reach everyone. That is something we try to do with our clinicians, researchers, and pharmaceutical companies. And now I really thank all of you. I thank all of you for this extraordinary work. And now I give the floor to Ilaria, who's going to introduce the session. We'll close this session around 12:30, and then at 3 p.m. We'll have a musical moment. This is a musical band that sings, well, little songs of comics. And then we have another session at 3:45, present and future of clinical and pharmacological management. And then at 6, we have another session on the psychological aspects in the shift from infancy to adolescence. And we hope you can stay with us for the whole day. I hope you like our conference. You can share also your photos while you are following the conference from home using hashtags conf 2021 or parent project. And we are on live on YouTube in English, and Facebook we are on live in Italian, and on our site you find the recordings of all the sessions of the other of the past days of conference. So on our website, you'll find all the recordings. And now I give the floor to Ilaria, and a good day. Thank you, Cristina. It's a great pleasure to be here with you today for this fourth day of conference. Of course, it is slightly atypical, but it is full of meaning. This morning session has to do with the importance of genetics and to what extent the genetic diagnosis and the type of mutation can, in some cases, be a determining factor to have really tailored therapies. We all know that DMD and BMD are genetic diseases. They are due to the mutation of a gene. The gene is the dystrophin, and identifying this gene, I mean, the gene was identified more than 30 years ago, and the characterization of the very many mutations that are possible for this gene. It is a huge gene, the largest gene we have in our cells. And so the identification and characterization of these mutations led to the development of a series of tailored therapies trying to correct the genetic defect that is at the origin of the pathology. Of course, that only applies to some types of mutation, not for all of that. So exon skipping or the correction of nonsense mutations. And we speak about these molecules that are being studied or are under trial. There are some of these molecules that have already been approved, clinicians and researchers, as well as representatives of the different companies that are developing these studies. And the introduction will be guaranteed by Professor Alessandra Ferlini. She's a neurologist, she's a genetist, she's the director of the unit of medical genetics of Ferrara University, and she is the coordinator of trials in her center, and she's truly an outstanding reference point for our community, our families, and especially for all the aspects that are linked to genetics, to the genetics of the disease. And today, it is absolutely clear how essential it is to have a precise genetic diagnosis. This was not the case till, I don't know, 10 years ago. And when the diagnostic solution for families was just based on muscle biopsy. And so that was it, as Professor Mercuri told us yesterday. Of course, you can watch past sessions again and again, as Cristina told you. And Parent Project was really essential over the years, and that together with the very important cooperation of Professor Ferlini to try and make people aware of this situation, and so that all families could have a precise and confirmed genetic diagnosis. And all that happened even before such studies were available in Italy. So I must say we were very well prepared when these studies or these trials reached our country. So I ask all speakers to speak slowly, to respect time limit, and please, all those who are listening from home, you can write your questions in the Q&A part of the Zoom bar, and I immediately give the floor to Professor Ferlini for her presentation. You have the floor. Thank you.
There's no sound. She's on a mute mode, I believe. Yes, here I am. Let me start from the beginning. You know, I'm always mute when conferences, when I go to conferences, so sorry. Anyway, thank you very much. I'd like to thank Parent Project. I'd like to thank Ilaria for her very nice words, and I'm certainly grateful to the association for the work we've been doing together all these years. So it's always a pleasure to be with you on the occasion of the international conference, however virtual it may be. But I mean, let's try to, you know, hug, however virtually, through our presentations and interactions. So here are my slides. I mean, my task is to introduce you to this very important session. I believe you can see my slides, right? Asks the speaker. Okay, so my presentation will not be easy. I mean, it wasn't easy for me to introduce you to today's session because my task is to try and let you know about how genetics works and how we might want to use the genetic data for actually accessing the currently available therapies. Through Ilaria's overview, you know that that is actually the case. These are my disclosures since I cooperate with other, you know, hospitals or companies around the world. I am involved in the Sarepta trial and other trials. Anyway, let me start with the dystrophin gene. I believe you know it all about dystrophin by now. Anyway, let me tell you, it's a gene that we've studied in depth. Actually, as Ilaria said, the first parent project idea with Filippo, whereby to extend the DMD diagnosis to all, precisely involved a better understanding of this gene. And at that time, of course, we did not have all the tools currently available to us. Anyway, this is a gene that is a sort of a pilot gene, as I like calling it, for medical genetics, since if we can use it to diagnose its associated diseases in order to find effective therapies, which seems to be the case right now, although, however, partially, well, then we'll probably have made a remarkable achievement, because quite frankly, there are not many genes as complicated as dystrophin, quite frankly. There are metabases that are even larger than the human genome, and then there are 79 exons, plus a certain number of isoforms that are particularly relevant in modulating this gene function. As I'm sure Professor Mercuri told you yesterday, in DMD and BMD, we have the involvement of the skeletal muscle as well as other muscles such as the heart, as well as some cognitive aspects. So the dystrophin gene is indeed a pillar, if you wish, of what I've said so far. So here you can see it in the bottom of this slide. You see the different exons, the 79 exons with all their functions. And this region here, basically accounting for the protein, includes a central region, which is, as I said, very, very large. It's almost like a gene family, actually. Well, this is the resilient part of dystrophin, if you wish, the one that goes under compression and decompression all the time during the muscular function. And this is the genotype. We now know a lot about the so-called mutational spectrum of the dystrophin gene. This is a cake showing a general framework of all mutational pictures. I might add that this is not the same all through countries and all through ethnic groups. So just think of Northern African populations or the Caucasians or European populations. Again, this is not the same all over. However, speaking in very general terms, it seems like the mutations occurring the most often are the so-called deletions followed by duplications. Together, they account for 78% of all mutations, and they are known as CNVs, copy number variations. Basically, they account, let me stress that once again, for the biggest part of dystrophin mutations. And then we have the so-called small variants, the nonsense in red, quite a lot of them compared to the other slices of the cake. Then the so-called frame shift mutations, they are definitely pathogenetic. And this is, I mean, they are known as you know, losing or gaining by a number that is not 3. Anyway, they certainly lead to a loss in the reading frame. Very, very rarely it may happen that, you know, we find them somewhere else apart from DMD, but then we've got the splicing mutations basically within the sites known for the right transcription of the genes, because all exons are supposed to be included in the messenger. And then the missense mutations account for a very small portion, variations of an amino acid. This is what they are about. So this is a spectrum that we genetics researchers are supposed to consider whenever we draw up diagnosis flowcharts. And this is a sort of a literature review regarding both DMD and BMD. And as you can see, mutations may vary in a different way from one disease to the other. And this goes on a cross-cutting basis through different ethnic groups. Deletions account for almost 80% of all mutations, otherwise duplications, but you can see the differences in the scores between DMD and BMD. And then what about these small mutations, as we call them? Well, nonsense mutations definitely occur more often in DMD than in BMD. The same goes for frame shift mutations, as I said before. And this basically means that mainly the difference between BMD and DMD is accounted for by deletions, which seems to support the famous reading frame theory that is very well known, and that basically came soon further to the discovery of the dystrophin gene. So especially deletions, if they are in-frame deletions, they are very often associated to a milder form of muscular dystrophy. Now, back to the flow chart. Here you see a list of the possible diagnosis opportunities in DMD. How can we come up with such diagnosis? Well, first and foremost, with the so-called MLPA technique. Then we get the sequencing. Well, sequencing may be based on the Sanger technique, which is the conventional one. Otherwise, novel techniques such as the NGS. And then, of course, the RNA analysis. I'm sure Dr. Falzarano told you about this. It's very interesting, actually, because it's very sensitive to detecting very rare mutations in dystrophin. And then CGH. Well, this is basically a technique that is a bit more accurate than MLPA, but there's a cost-benefit ratio to be considered, since this one is definitely more expensive and therefore should be used only in very specific cases. For example, when we have atypical phenotypes with some syndromic forms somehow associated to a BMD or a DMD picture, therefore CGH may detect both the dystrophy gene as well as the regions neighboring the genome. Now, the EMQN is responsible for the European guidelines for genetic testing. Actually, such guidelines were reviewed last year, and I had the honor to be in the international team that was supposed to carry out that task. And actually, we did update our flow chart, well, quite similar, of course, to the previous one, but we defined 3 different levels. Level 1, it tests all DMD exons, then DMD sequencing. And this is precisely what I want to focus on, because if the testing is negative, well, then maybe there's also a clinical suspicion whereby RNA should be considered, in which case so far, namely up until a few years ago, we had only biopsies, whereby now we can use urinary cells for this testing. They are getting more and more popular, especially for some protein transcripts. So we are currently considering them as a testing tool, thanks, by the way, to a specific funding campaign by Parent Project, whom, of course, I wish to thank. Now, we are now supposed to come up with a correct interpretation of all the variants that we may have detected in the meantime. And we know that some specific mutations make given patients only eligible to some specific therapies. Let me start with the Translarna drug, whereby only nonsense mutations bearing patients are eligible. As for the exon skipping approaches, not yet approved in Europe, I might add, well, here only patients having some specific exon deletion groups are eligible to being included in that testing. And then, of course, gene therapy. Today, we know that several companies are involved in several gene therapy settings or opportunities. But here again, we know that for some mutations, it is simply impossible to have a patient eligibility to such therapies. Hence the relevance of the genetic testing to be properly interpreted, I might add once again. This is just to show the complexity of such reporting and interpretation. Here are some examples, of course, anonymous examples of mutations and examples of how we define for example, the mutations that have been detected. So we say there is an absence of amplification in this specific case, which seems to be a very relevant piece of information. So once again, first of all, there must be a genetic report. I mean, before actually communicating the diagnosis to the families. We usually try in our genetic reports also to include the type of mutation that is present or not, because we want clinicians to be supported by our testing and results. And I can understand sometimes reports may be drafted in a difficult way. Sometimes nonsense mutations especially are simply not defined and considered from a very difficult again a wording perspective, but we try to actually go into that possible definition, because again we want it to be as clear as possible. So what we're trying to do is to provide through our reports all the relevant data. Now, in order to make such a dialogue, such cooperation, such a multidisciplinary cooperation easier, we have envisaged a telegenetics project. Its name is TeleNewCare. We are the pilot people in it, if you wish. There are 3 centers in Italy currently working within this framework. Well, it's basically about the use of telemedicine in genetics. And when we envisaged this project, there was no coronavirus around. So it seems like we had somehow, thought that this might be the case. So anyway, its name again is TeleNewCare. We are using it for neuromuscular diseases as well as for heart diseases. So we use the Emilia-Romagna region platform from central Italy. Its name is Lepida. And you see that here are the reference centers, one in Messina, then Rome and Milan. And there's a sort of a network that starts from these centers for the sake of patients counseling. So here is our protocol. Inclusion criteria include people underage as patients who must come to see us accompanied by their parents, of course. Patients can book their examination or their interview through this email address, and everything can happen on an online basis exactly as though it were on an in-presence basis. Then there's a written report that after the counseling is always provided to the patient via mail. This is the group that is dealing with that. Francesca Gualandi is the one to be particularly acknowledged for that. She's really been great, of course, with the Nemo Center colleagues. But of course, we are ready to extend this to the whole of Italy. So I'm almost done. Why is it, to conclude, that genetic diagnosis is now compulsory? Well, for several reasons, of course, for the sake of prevention or for confirming the diagnosis, but also for the access to already available therapies or customized trials. And of course, for the sake of the families, all in all. So thank you very much. I wish to thank my team in Ferrara. Thank you. Thanks.
Gloria si attacca adesso. Grazie, professoressa Ferlini.
Thank you, Professor Ferlini. Thank you very much. Thank you. Very clear and very brilliant presentation. Of course, the questions will be at the end of the session. Well, on the first day of our conference on Wednesday, there was this project on biobank and stem cells, urinary stem cells, and that intervention, of course, is available on our website. It is a project we are very keen on. So thank you. Thank you. And now I give the floor to Luigi Picaro, who is a senior medical director of Sarepta Therapeutics for Italy and Greece. Sarepta is an American pharmaceutical company, one of the first to work on exon skipping strategy for DMD. And it was the first company in the United States who received the approval for its molecule, the one skipping exon 51. And now I give the floor to Luigi Picaro, who will be telling us about the very diversified program of exon skipping of Sarepta. They have, I think, 14 programs that are in clinical development with different oligonucleotides, PMO and PPMOs. Luigi, you have the floor. Thank you, Gloria. I hope you can see my screen. Yes. Good morning. It is a great pleasure for me to be here today, even though in remote, apart from Italy and Greece, I'm also responsible for the south of Europe and the Middle East. And today, I wish to give you some information about our lines of research on RNA, a disclaimer. My presentation has only educational purposes and solely intended to provide scientific information on Sarepta's therapy. It has no promotional objectives or is not meant to encourage people to be included in our trials, because of course that decision is always up to the physician who's treating the patient. Gloria spoke about Sarepta. Thank you. Sarepta goal is to develop medicine that can really change the history of Duchenne, and our objective, our ambition, and the reason why we work is satisfying or treating rather 100% of individuals with I'll try and give you an update on some projects that are linked to our RNA platform. And it has two lines, so to speak, PMO and PPMO. These are very promising second generation drugs. Both in the first and in the second line, there are projects at different steps of development. As for PMOs, there are two molecules, as Professor Ferlini mentioned. Two of them are in the United States and one in Israel. These are SRP 4051, both in the US and in Israel, and the SRP 4053 only in the United States, whereas SRP 4045 is still being reviewed. Then there are other projects that are slightly more backwards, so to speak, but they are still within our lines of development. And the same goes for PPMO. There is one drug that is more advanced, that is already at the clinical stage. And this is for patients with a skipping of exon 51. And then there are others that are further up the road, but they're still present in our line of development. I'd like to start with PMO technology. And with Sarepta's RNA platform is based on these compounds. They are phosphorodiamidate morpholino oligomers. Well, this platform has a very high specificity, whereby we can really tailor our intervention to that bits of the RNA we want to work on. And these are compounds that are extremely stable. They resist to the enzymatic phosphorylation. And this enables us to design candidate drugs in a reasonably short time. And these compounds are well tolerated thanks to the charge neutral backbone. How do they work? I expect you know about it. PMO bind to a target sequence on the pre-mRNA of the targeted exon. And so we have the famous exon skipping mechanism during the elaboration of mRNA. So there is a recovery of the reading frame, and so the production of a dystrophin that is shorter, but still functional. I'd like now to speak about three programs that are extremely important, and they will involve 30% of patients with DMD. The first one, starting on the left, is the one concerning eteplirsen. They have, for patients who have a mutation that can be solved with exon skipping, 51 exon skipping. There is one part of bone finding, so 2 doses, 100 or 200 milligrams per kilo. And once we have identified the appropriate dose, then we make a comparison with the dose that has been approved in some countries, that is 30 milligram per kilo body weight. Then there are other two programs, the golodirsen for patients with for which it is exon 53, and a third exon 45. Both these projects have completed phases 1 and 2, and we have an ongoing study for both drugs that is called Essence. It is an active studies. We are still enrolling patients. Then I'll be telling you in what countries we are enrolling patients. It is a worldwide study. It is double-blind, placebo-controlled study with an arm per each of the two drugs, and there will be an open label after the double-blind stage. And as for all the patients who took part in the other two trials, for these patients as well, they will have the possibility of being enrolled in an extension study that will enroll 260 patients. The Essence study is ongoing in the US, Canada, Belgium, France, Germany, Israel, Italy, Spain, Sweden, United Kingdom, Ireland, Greece, Denmark, Poland, Hungary, Czech Republic, Bulgaria, Russia, Serbia, China, Brazil, Mexico, Argentina, and Australia. It is truly a global study. I had already mentioned PPMOs. They are second-generation drugs, and they contain all the characteristics of PMOs as specificity, stability, tolerability. And on the right of the slide, you see that they contain a conjugated peptide that permits an increase in the penetration of these molecules in muscle cells, including heart cells. This may lead to a easier administration schedule if compared to PMOs. Here again, we have a program that is at the clinical stage, 5051, and this compound has completed the first phase in man, and now we have another study underway. The name of the study is Momentum. There is a phase A, aimed at setting the single ascending dose, so safety essentially, and then that will be followed by a second phase, assessing the drug in the studying the variation in the expression of dystrophin plus a number of other parameters, and it will enroll all those who participated in phase A, but plus an extra 15 patients, additional patients, and then all of them, they can have access to an extension study. Before closing, I'd like to stress a couple of concepts that are very important for us at Sarepta. We know we don't know. What we know is that we don't know. We are working in cooperation with partners, companies, research institutes, and we do that to learn more and to speed up our projects, and also the possibility of making these drugs available to clinicians and patients. And another aspect that is quite essential for us is, our gratitude vis-a-vis patients and their families, not only because we are fully aware that without patients and families, none of our development projects and programs could move forward, but also because we learn from you. We learn from you in terms of strategies for clinical studies, sometimes even design of studies, selection of endpoints, informed consent, and so on. And that is something I'm very glad I can say. And the reason why we are here, we are very glad we are here to share with you the result of our work. Thank you very much indeed. And of course, I'm most willing to answer your question. Thank you. Your questions. Thank you.
Grazie Luigi per questa presentazione.
Thank you very much, Luigi. Thanks. It's very interesting to see the different degree of involvement by companies, but they all seem to be, going ahead with their research, thus providing our patients with always novel products. So please stay with us for the Q&A session. And now the floor goes to Benjamin Younger from NSA Pharma. Benjamin is going to deal with the latest developments of Viltolarsen for exon 53 skipping and their phase 3 study that is being carried out also in Italy at the Gemelli Hospital in Rome. This is a molecule that has been approved by FDA. So Benjamin, you have the floor.
Thank you very much, and good morning. I will be presenting in English, so the interpreters, thank you for being here. Good morning, everyone. Thank you for coming today on a Saturday, and thank you to Parent Project for having us. We're very excited to present our data with you and share with you our clinical updates. My name is Benjamin Younger. I am a neuroscientist and medical liaison for NS Pharma. And I'm excited to talk about our clinical data. Thankfully, I think the science of exon skipping has been explained very well by previous speakers. There's been some really exciting research so far, and we'll jump right into the clinical data from there. I may be making some forward-looking statements, so here's the standard disclaimer. So again, I'm with NS Pharma. We are part of Nippon Shinyaku, which is a 102-year-old company. So we are based right outside of New York City, and our other headquarters are in Japan. So Viltolarsen, also known as Viltepso, is being studied in patients with a mutation that is amenable to exon 53 skipping. And so it is a phosphorodiamidate PMO. And exon 53 skipping mutations account for approximately 8% of the Duchenne population. There is some overlap in amenability. So this pie chart adds up to more than 100%. And so there can be some discussion with a physician about the appropriate medication. Viltolarsen has been studied for several years. In the US, it was granted rare pediatric disease and orphan drug disease designations, as well as fast track. It was approved in Japan by the Ministry of Health and by the FDA in the United States last year. And we currently have our global phase 3 trial, which is underway, and I'm happy to describe with you shortly. And here is a brief summary of the available clinical data, the clinical studies that have been accomplished so far, some on the left side in Japan, and on the right side in North America, United States and Canada. And so the data that I'm about to show you is from our phase 2 study, which looked at the doses here, 40 and 80 milligrams per kilogram. This is a weekly infusion every week. And the duration of this study was 24 weeks, as well as the long-term extension study that followed. And our phase 3, as I mentioned, is underway. So here's the rundown of the phase 2 study. After a brief safety period, which was compared with a placebo, 8 patients were randomized into the 40 mg per kg group, milligram per kilogram. and another 8 received 80 milligrams per kg. And at the end of the 24-week period, all 16 boys enrolled in the extension study. And the age range for these patients were all 4 to less than 10 years old at study onset. Primarily, the outcome that we were looking at was dystrophin protein production. That's measured by Western blot, as well as safety, tolerability, pharmacokinetics. Some of the secondary outcomes for this study were dystrophin mRNA, looked at by RT-PCR, as well as protein via mass spectrometry and immunofluorescence, as well as these clinical assessments of function. And as I mentioned, these patients were all 4 to less than 10 years old, all had a mutation that was confirmed to be amenable to 53 skipping. Some other standard inclusion criteria here, function, lab tests, and the stable dose of corticosteroids for at least 3 months. And you can see the exclusion criteria here. And at the end of 24 weeks, the primary outcome measured was dystrophin protein. And we saw an increase from pre-treatment of 0.6% on average for these 8 patients. At the end of the study, on average, all the 8 patients had 5.9% of normal levels of dystrophin protein. So this was a statistically significant increase, and all 8 increased. In terms of the safety profile, you can see some of the most common adverse events reported here. The most common were upper respiratory tract infection, cough, fever, and reactions at the site of infusion. So there were no serious adverse events related to treatment, no discontinuations of the study, and no deaths. And as I mentioned, all patients in the study enrolled in the ongoing extension study. So that was the phase 2. We have an ongoing phase 3 clinical trial for boys with Duchenne amenable to exon 53 skipping. And this will assess the efficacy and the safety of viltolarsen in patients. And this trial is known as RACER 53. So this will be a randomized, double-blind, placebo-controlled study in ambulant boys. The age group here is age 4 to less than 8 years old, and the duration is 48 weeks. So this is a weekly intravenous infusion of viltolarsen at the dose described earlier, 80 milligrams per kilogram, or a placebo control. Unlike the phase 2, the primary endpoint here is function, specifically the functional test known as time to stand, so the change in the time to stand from supine position. Other secondary endpoints are other functional assessments seen here you may be familiar with, especially the North Star Ambulatory Assessment, as well as other tests of function and some physical exams. Again, 4 to less than 8 years old, a confirmed mutation, able to walk independently, the baseline time to stand value of under 10 seconds, and again, the stable dose of corticosteroids. A whole lot of exclusion criteria. a history of infections, acute illness, or severe cardiomyopathies. All of these are available. This is all searchable. You can read it at your leisure. This is on clinicaltrials.gov under RACER 53. Or current investigational drugs within the last 3 months, or 5 times the half-life of that drug, or any gene therapy. And so this is what the trial will look like. So after screening and randomization, patients will be randomized into either of the 2 groups and studied for 48 weeks, after which all patients will receive biltolarsen. And as I mentioned, all of this information is online, so you can find this and read it at your leisure. This is RACER 53. I wanted to thank you all for your time, and I'm happy to answer any questions if you'd like to submit them here, or I will answer during the Q&A session at the end. So thank you very much.
Grazie Benja, vai Gloria.
Grazie mille. Sì, le domande sono tutte alla fine della sessione, Benjamin, quindi per favore, anche se è sabato,
Sorry, yes, that's true, Benjamin. Questions will all be asked at the end of the session, so please stay with us. And now it is my pleasure.
Romesh Subramanian.
Now we give the floor to Romesh Subramanian. I hope we got the surname right. He is a scientific director and co-founder of Dyne Therapeutics. We are very glad to have you here with us in our conference. This is the first time you come to see us, and we are sure that we can start a long and fruitful cooperation. Thank you, Romesh, and you have the floor.
Great, thank you very much for the invitation and for the honor to present to Parent Project Italy. We certainly appreciate it with the opportunity. I'm Romesh Subramanian, Chief Scientific Officer and founder of Dyne Therapeutics. Before I begin, just a reminder that during my presentation, I'll be making some forward-looking statements that involve some risks and uncertainties. So at Dyne, our mission is to develop life-transforming therapies for patients with serious muscle disease. So let me explain some of the platform that we have. We've developed what we call the FORCE platform. It's a proprietary platform that enables modern oligonucleotide therapeutics for muscle disease. You've heard some great talks which have used oligonucleotide therapeutics. We are hoping that we can also provide a solution for patients in the future. So our platform has 3 parts. So first is an antibody. It's a fragment of an antibody, so we call it a Fab. And this Fab targets transferrin 1 receptor, which is highly expressed on the surface of muscle cells. Second, we have a linker. This linker that we are using is a clinically validated linker, so it takes away a lot of the risk in this molecule as well, and helps to connect the antibody to the payload, which is the third part. The payload is what we are using for DMD because we need to skip in the nucleus, is a PMO. As you know, PMOs are effective in the disease as well. And this PMO, being single-stranded, we expect it to get to the nucleus and skip the appropriate RNA. So with our platform, we have designed it to deliver significant advantages, such as targeted muscle delivery, addressing the genetic basis of disease, a redosable and titratable medicine with enhanced tolerability and durability. Moreover, with our manufacturing, we can reduce some of the manufacturing costs and development time as well. So all those together, we are hoping to bring our lead programs into clinic in DMD. So let me tell you a little bit about our lead program. So as you know very well, I don't have to tell you about DMD. It's a muscle disorder. we do believe that there is significant unmet need for patients, and it is our duty to try and get better medicines for these boys. At Dyne, we are building a best-in-class targeted exon skipping franchise. So let me walk you through the data. Our lead program targets exon 51, and we'll be addressing other exons as well in the future. So here, FORCE platform achieved enhanced exon skipping compared to naked PMO in DMD patient myotubes. So this is a patient myotubes that is amenable to skipping of exon 51. On the y-axis is exon skipping, percent exon skipping. When you treat to the PMO in red, you see a certain amount of skipping. But when you connect that PMO to our Fab antibody, now you've increased that amount of skipping. We think that can be beneficial by increasing skipping. And so this molecule is moving towards clinic. Let me share some of the data we have from the animal models. For the mouse models, we've evaluated our FORCE in the MDX model, and we demonstrate that we achieve enhanced exon skipping compared to published data from a naked PMO or a stereo pure ASO. So let me walk you through these slides. So this is the quadriceps. With low doses of our molecule, single doses, we get enhanced exon skipping. In the quad, up to 66% exon skipping with a single dose, as opposed to naked PMOs, which are at 21%, or the stereo pure ASO, which was at 13%. And most exciting is that we not only skip in the quadriceps, but we also skip in the diaphragm, as well as the heart, which, as you know, is very hard to deliver molecules and skip and produce dystrophin. In the heart, we see at the highest dose we've tested so far, 35% exon skipping. And most importantly, this dose-dependent exon skipping results in a dose-dependent increase of dystrophin expression. So in the Western blot are the 3 doses we've used, 10 milligrams per kilogram, 20 milligrams per kilogram, or 30 milligrams per kilogram. And if you look at the histogram, this quantifies the amount of dystrophin. So we get at the highest dose, 30 milligrams per kilogram, dosed once IV, somewhere between 8 to 10% of dystrophin production in these mice. So significant amount of dystrophin production is seen. This dystrophin is also localized to the membranes. So with our FORCE platform, we have restored dystrophin expression on the membranes of those cells. So here is wild type mouse. This is the MDX mouse. So you see very little dystrophin staining. This is the naked PMO. You see a few positive fibers. And here, extreme right, is Dyne's molecule. You see a large number of positive dystrophin fibers, and dystrophin is localized on the surface or the sarcolemma. And as we all know, if you increase dystrophin expression in the sarcolemma, you'll restore muscle cell integrity. So the muscle will become less leaky. So we measured serum CK levels. As you know, if the muscle is leaky, you can measure it in the serum. Once you restore the muscle membrane, you should see decreased serum CK. And we show you here that a single dose of FORCE significantly reduced serum creatine kinase. So this is 2 weeks after the single dose. This is MDX in black. Red is a naked PMO-treated MDX mouse, and this is with our Dyne molecule in the blue bars. So 2 weeks, we have decreased CK levels, and we continue to decrease it out to 4 weeks. And this is after a single dose of our medicine delivered intravenously. Exciting news, of course. So we evaluated these molecules in a functional study at a CRO, or a company that does it for hire. And they were blinded to the study. Here, FORCE demonstrated functional benefit with a single dose. The first test, called the home cage running wheel, mice are allowed to run on a wheel, and you measure it by video. This is the distance traveled. and this is the time of the day. Between these two dashed lines is the dark period when mice are active and they run on the wheel. So as you see, the gray circle is wild type with a high peak of activity. Black is MDX. They fatigue faster and the muscles don't work as well. So they have a lower peak of activity. Red is the MDX mouse treated with a naked PMO. And blue is the MDX mouse treated with Dyne's molecule. So as you see with force platform treatment, you're increasing the level of activity from an MDX level of activity to almost a wild type level of activity. And this is over 12 hours of running. So we do believe we are providing benefit to skeletal, cardiac, and diaphragm in these mice. A second assessment was called a hind limb fatigue challenge. So the mice are allowed to move in a circle in a cage and measured by video. And then they're forced to stand on their leg for 10 minutes. So it makes the muscle weak or fatigued. And then they're measured again in that cage by video. And you look at how much loss of motion they have after the muscle is fatigued. Wild type mice in gray lose 20%. MDX loses 70%. The PMO treated did not recover it with a single dose of the PMO, but a single dose of the Dyne molecule reverted the mouse to almost a wild type level of activity. So these are exciting preclinical data that we help to build our Exon 51 franchise, but we're also developing a global DMD franchise to address up to 80% of the DMD population that's amenable or can be addressed by exon skipping, which is very exciting. So just to summarize our program, in the preclinical models, we achieved effective exon skipping, dose-dependent increase in dystrophin production. The dystrophin is localized in the right place in the sarcolemma. We reduce serum CK levels. We demonstrate functional benefit. And we have a lead molecule that clearly demonstrates exon skipping in a patient cell line. So we're advancing this molecule using established clinical and regulatory path. And we have an opportunity to accelerate all the other franchises that are coming behind, which include 53, 45, and exon 44. So this will be one of the 3 INDs that we plan to submit very shortly to the FDA in the US. As you know, Dyne's a small company, and this was the last rare disease day when we could actually get together as a family. We truly work as a family, and we hope to serve families of patients. And with our medicines, we expect to target the genetic basis of disease and either stop or reverse disease progression. So I thank you very much for your attention and for the opportunity to present at Parent Project Italy.
Grazie Romesh, anche noi ci auguriamo di vederti nelle nostre prossime edizioni delle conferenze.
Thanks a lot, Ramesh. It will be nice to see you soon again in presence. And in the meantime, that picture is really great. Congratulations. Now, I wish to thank you all as speakers for coming into our video connection very early this morning. So thank you very much for being so accurate, if you wish. And now the floor goes to Dr. Giulio Cossu from the University of Manchester. Well, he's certainly an expert in the field of muscle molecular biology. He's been dealing with stem cells for quite some time, those stem cells that can differentiate in the muscular tissues. So Giulio will talk to us about his pipeline clinical study. There's a possible candidate for cell therapy for Duchenne. It seems like there's a combination with exon skipping, but we give him the floor. and he will tell us. Thank you very much. Good morning. It is obviously a pleasure to be with you again. I'll be speaking Italian actually after some 10 years in England. I am still unable to speak English, but I seem to have forgotten Italian. So I'm not sure which language I'm going to talk in, but hopefully someone will understand what I'll say. So here are my slides. Actually, for many years now, we've tried to find a therapy for DMD through cell transplantation. I have no disclaimers, but in the bottom of this slide, you can see the different sponsors behind our trial. There may either be public sponsors or charities. Some 15 years ago, we envisaged a cell biology protocol based on mesangoblasts. They are cells all orbiting around the vessel walls. Well, they are advantageous compared to the satellite cells that everybody uses. They are advantageous insofar as their receptors allow them to cross the vessel walls when there is an inflammation, which is indeed the case, as we know, of all DMD muscles, whether in humans or in animals. Hence, the relevance of the regeneration sites, where the cells, if coming from a donor, say a sibling, are compatible, of course, an HLA compatible sibling. That was the trial we carried out a dozen years ago in Milan. So they may regenerate in a given kind of a gene, in a natural gene, namely, otherwise in a therapeutical gene, which implies problems regarding the size of the gene. I'm sure you've heard about that already. So we used this protocol in 3 different mouse models, 3 different muscular dystrophy mouse models, and in only one big animal available at that time, that is the dog. So we carried out all our toxicology analysis. We even validated our outcome measures, because at that time, the outcome measures had not yet been made available by the NMD. Then we prepared our cells with the Molmed company at San Raffaele Hospital, where I was working at the time as ATIMP. Then we got the regulatory approval in Italy, and we did go through phase 1 and 2A of our trials. So 5 DMD patients, 4 intravenous infusions were carried out of these HLA compatible mesoangioblasts derived from a sibling. The results were the following. The trial was generally safe, apart from just 1 adverse event. Efficacy was transient, but certainly much lower than the one observed in both mice and dogs, for different reasons. First of all, because the cell dose was lower, because the disease was more advanced, and also because, you know, all animals use 4 limbs to walk. We are the only animals actually, together, of course, with the other primates, walking on 2 limbs. Therefore, the posture and the gait change completely if, of course, only the lower limbs are to be used as a support, so to speak. And all patients were on steroids. Anyway, in effective cell therapies for congenital immunodeficiencies, for example, or epidermolysis bullosa, well, within that framework, an ablation can be carried out, or I mean, the skin can be surgically removed so that at least 80% of the cells treated are either healthy or genetically correct. But since you can't remove most of the heart or the muscles or the brain, well, then the muscle colonization by the transplanted cells is destined to be too low to actually be therapeutically effective. However, if we compare the dystrophin level as expressed in the GRMD that had provided with the worst response with the level of dystrophin in the patients that was the best responder, well, then the differences are not that many. Therefore, we realized we were to rather improve the efficacy of the treatment. Using more cells? No way, because almost 1 billion cells had been transplanted. And for the first time, non-hematopoietic cells were being injected into the arterial circle. So 3 passages were necessary, were needed. First of all, we needed a proof of concept clinical phase, then transplantation should be optimized, and then we had to reach out to those muscles such as the diaphragm or the heart that were particularly difficult to be reached out to. When that is done, we'll be into the actual phase 2. So the protocol can be improved by enhancing adhesion to the endothelium as well as the its crossing, but most of all, which is the main topic of my presentation, we need to correct the nuclei of the muscular fibers. Let me give you an idea of that. Our patients were on steroids, as I said, and the assay that was carried out showed that in a healthy endothelium, no stem cells are bound, but when TNF-alpha mimicking an inflammation is used, well, then if the Flazacort has been used as a pre-treatment, well, basically, the situation changes dramatically, and it seems like we had started with the wrong foot, so to speak. Anyway, what's even more important is that the genetically corrected cells from the patient should be used as a sort of a Trojan horse going into the muscular fiber. By the way, lentivirus is used for correcting the gene, expressing a small RNA first designed by Irene Bozzoni in Rome and then used by French teams in several preliminary tests. So what we get is that we have many nuclei in a muscular fiber, so the small RNA may make up a riboprotein. So the quantity of dystrophin that is produced, if you have 1 corrected cell and 28 or 29 dystrophic cells, then you will mimic a colonization by, say, 1 or 3%. In this case, it was approximately 1%. And therefore, the quantity of dystrophin that is produced is not I mean, it's much higher than the one that you would have expected. The Western blot shows that by diluting a healthy cell with 29 dystrophic cells, you will not see any more dystrophin. Whereas when you do the same thing, but with a cell that has been genetically corrected, then you will still see dystrophin due to the fact that the small RNA, these small red dots, from the few cells that have undergone correction, well, they travel across the muscular fiber, thus going into all nuclei, even if very far away. We have some very first in vivo experiments, of course, because of the pandemic. We had to restrict those experiments. But anyway, both in dystrophic rats and in DMD mice with deletions in two different exons, respectively 51 and 52, we get a much higher production of dystrophin than the one expected by injecting healthy cells. So to prove that, 2 years ago, we started a phase 1 study by using genetically corrected patients' cells. We used the EBD muscle, and the cells were transduced with the vector, which was a lentiviral vector. Of course, safety and efficacy were all properly tested, also through the typical ribosome measures. And here is the actual product preparation. Before injection, however, what should have happened is that injection should also regard the contralateral muscle. You see, there's a very high quantity of protein in these cells, but because of the pandemic and other logistical problems within our university, which I won't go through, have made it impossible for us to move on to the second phase, whereby also the contralateral muscle receives the injection of such cells. Anyway, the same should concern the thumb muscle, where also the injection should take place. And within that framework, also patients having gone through a loss of ambulation are supposedly included to measure of course, the grip strength. Anyway, the trial is ongoing. In Manchester, the clinical PI is Dr. Imelda Hughes, and here is the list of the whole members of the team, including Francesco Montoni, who certainly needs no introduction. So we believe that clinical efficacy with this approach can easily be obtained once, of course, we've gone through all the other phases that I mentioned. It's still a long way, as you may have gathered, but for once, regarding cell therapy, we may start seeing a light at the end of the tunnel. Thank you.
Grazie infinite Giulio, il tuo italiano era
accettabile.
Thank you, Giulio. Yes, your Italian was pretty good. Giulio, apart from being an outstanding scholar, sorry for the pink dots on my face. It's just the effect of the sun. Giulio Cosso is also an excellent communicator, apart from being an outstanding scholar. And now we have a video from Luca Bello. He's a neurologist from the Padua University, one of our most important reference point in Italy. We wish to thank him because even though he could not be personally present, he gave us his contribution with this video, and then he will be attending the Q&A question, and we wish to thank him for that as well. We have this video from Luca Bello. He'll be speaking about nonsense mutation, and I'll try to get away these pink dots. Well, today I'm speaking of the nonsense mutations and the effect it has. So by translation, we mean that shift from the mRNA messenger to the protein. The ribosome reads the words of the genetic code. These three nucleotides carrying amino acids, so they decodify this message and link to the protein. All these three-letter words refer to different amino acids, but three specific codons, U, AU, UAC, UAA. Well, these are stop codons. When mRNA moves to be translated, there is this initial signal, and it reaches this red stop that is the normal one. But if due to a mutation there is an anomalous stop in the middle of the protein, the RNA dissociates. So it's not so much the problem that the protein is truncated, but rather that this faulty RNA is seen by the cell as detrimental and eliminated with a specific mechanism that is called nonsense mediated decay. In well, in these type of mutation, you see these mutations with more exons, and point mutations are about 1/3, and 1/3 is nonsense. So nonsense account for 10-15% of DMD and a small part of Becker. If we consider dystrophinopathies as a whole, so all patients who have this nonsense mutation in dystrophin, a stop sign. Here you see in this graph, on the y-axis, the NSAA, so on the top patients who have an excellent maintenance of force, so they can jump and run, and on the axis from toddlers to adults, and you see a clear decay of the motor function that is typical of Duchenne. But there are some patients with nonsense mutation that have intermediate forms with maintenance of force during adolescence, or a clear Becker situation. Many studies have researched on this mechanism and why all this happens. Here you see that the great majority of mutations in orange here, so all along the gene, these are nonsense mutations. They lead to Duchenne, but there are many, the blue, that end up in Becker, and they cluster in some areas, beginning, center, and for the different exons there is a frequency, and you have the mutation of some exons that tend to be Becker. This is probably due to a spontaneous skipping of that exon if there is a nonsense mutation. So the message of this analysis is that exon skipping could be a solution for some nonsense mutation when the involved exon is in frame there, as in the case of exon 30, that could be solved simply by skipping exon 30. Another possible therapy used on small molecules is the nonsense read-through. The ribosome arrives again here at the stop mutation, early stop, but thanks to a small molecule that modifies its translation, it overcomes this anomalous stop signal with an amino acid and reaches the normal stop, and there the function is preserved precisely by the drug. And we restore the function. For some years now, we have known that some antibiotics are capable of restoring dystrophin in the MDX mice, but the development of this drug in clinical trials is limited by its toxicity. An American company has developed over 20 years molecules that is a targeted molecule to maintain this function, but without the toxicity problem. So preclinical studies have demonstrated this presence of dystrophin on the membrane. And then there was, there was a long trial. This is a phase 2A study at 28 days. You see that there is a recovery of dystrophin. These data are supported by more recent studies on 18 patients analyzed with a biopsy at 40 weeks and some others for a longer period with immunohistochemistry, chemistry, and another method as well. And here you see a phase 2B study based on the 6-minute walking test. Well, you see patients treated with this dosage, a good maintenance of the function, better than with higher doses, possibly due to pharmacodynamics, whereby the drug was better at lower concentrations. Then we have phase 3 studies, and that have used always the 6-minute walking test. It is a primary measurement. We know that it has had some difficulties because there is a strong variability. It's stable with patients who do well at 400 meters, and it declines very suddenly further down, whereas it is quite reliable between the 300 and 400 meters. Phase 3 study here, there is a sub-analysis precisely for these patients. And so here there is a significant difference. Well, here you don't see the difference in the distance lost, whereas that effect has been shown in the 300, 400. Here in the All-Star, you see the maintenance of the ability to carry out the different tasks on this scale in treated patients versus placebo. And so we have clinical significance of the efficacy of this drug. Different trials and this registry of a phase 4 of use of the drug after its approval in 2013. In the long term, we can see from this data coming from the 019 study, a long-term extension of patients that had been enrolled in other studies, that the age where they exceeded FVC over lower than 60%, so night hypoventilation, were well, that is more advanced than in the other cohort. A similar comparison has been done with another study, loss of ambulation, and there is an advantage in Translarna treated patients, but Translarna therapy is only for ambulant patients, ambulatory patients. we can say that what are the take-home messages? The nonsense mutation involve a significant minority of patients with DMD, whereas it is an exception with BMD, but it opens the way to, customized therapy. The drug was approved by EMA, approved specifically for Duchenne, and now it is available also in Italy, and further confirmatory studies are underway. Thank you for the attention.
Di oggi.
Thank you, Luca, and thanks, of course, to all the speakers. By the way, Luca Bello is available for taking your questions live, so to speak. Anyway, before going into the Q&A session, I'd like to say how relevant our patient registry is. So please do sign in. It is very important that you should do that. And I want to stress this precisely within this session, namely in the light of what we've heard about genetics. You know, if you are within that registry, you might be included in some mutation-specific trials. And in any case, all the information we collect and put into our registry are out there. I mean, the information is out there also for clinicians, you know, and physicians or genetics experts to read. So for those of you who provide the registry people with all the relevant information, will also contribute to developing new strategies, new therapeutical strategies, thus improving our knowledge about DMD. Well, our international conference has always been the time for us to meet the families, thus updating our registry. Of course, this, I'm afraid, will not be the case this year, but you know that we are doing that all the same, however, virtually or via telephone calls. And please do get in touch with us for such updating. Tomorrow, by the way, the very last session of tomorrow and of the conference will precisely deal with an aspect that is the so-called emergency card. Dr. Racca will be orbiting around this, that we from the patient registry believe is very, very important. So now on with our Q&A session. We start with one question, we the staff, because based on what you've said, some products have, for example, been approved in the US, but not in Europe. And this obviously engenders a sense of frustration in all our families, easy enough to understand. And in these very days, some articles are being published by several Italian newspapers about the story of one of our families. Actually, this family has been trying to have access to one of these treatments for years via the programs of early access that are available in our country for those drugs that have been approved even outside of Europe. Of course, we are side by side with this family, and therefore our question to Sarepta and NS Pharma specifically is the following. When will EMA get the application for approval of the drugs that have already been approved in the US? And what can we do as an association, and what can you do as companies to make this smoother, thus solving the problem problem of this specific family, but of many other families. Thank you. Let me start, Ilaria, if you agree. First of all, thank you very much for this question, because this is really, really a very important issue that that is very, very dear to us. Now, let me say something as an introduction. The EMA and the Food and Drug Administration follow two different pathways for what pertains to drug approval, which makes it obvious, which makes obvious the reason why one drug may be approved in Europe and not in the US, or the other way around. So EMA accepts to evaluate, sorry, FDA accepts to evaluate even surrogate endpoint products, which is not the case of EMA. So what does that imply? That in spite of the same data, we basically get an approval for one regulatory agency and not from another one. Now, what you have said regarding the exon skipping 51 drug, eteplirsen, already not approved, as everybody knows, but we are going on, you know, we keep going. We have always talked with the EMA people. It was the EMA that did not approve that drug. And we keep talking to them, not only for that particular drug, but also for other drugs that should be made available in the European Union. This will take long, you know, of course, regulatory agencies will have to examine all data. Sometimes they do not consider some specific aspects the way they should, as clinicians know only too well. As for us, we of course must accept what we get from regulatory agencies, but our data must have a clinical impact. So the answer is we are working at it. Hopefully we'll make it, but especially, or at least here in Sarepta, we work in the EMEA region, so basically in Europe, we are doing precisely that. Hopefully I've answered your question.
Sorry, I apologize for the language jump.
Okay.
But with NS Pharma, we're in a similar situation. We're approved by the FDA. We're currently working, we have efforts that are commercialization in Europe. I can't speak to it much more than that, except to say we're working hard, and I'm not sure what it'll take to speed the process up. I'm sorry, I cannot answer more than that.
Ok, ci auguriamo che la richiesta anche da parte di NS Pharma.
Well, hopefully NSA Pharma application to EMA will be as smooth as possible. And again, we shouldn't give up, you know, you shouldn't give up, and we should keep in touch. We must try and really be a massively relevant interlocutor for regulatory agencies, because, you know, boys grow up, and we need to keep going, but fast. Thank you. And now now question number 2. Okay. By the way, let me say that we're going to read out the questions, okay? Speakers have been kind enough as to say that they were also ready to answer in writing, but let's read them out so that everybody may be made aware of them. Gianfranco says, for Ataluren and Translarna, is this a drug that can only be used for nonsense mutations in in DMD. For those who have nonsense mutations in DMD, sorry, in BMD, what about DMD nonsense mutations? Good morning, this is Luca Bello. Good morning. Well, that's an important question, a good question, but the answer is going to be quite complicated. Actually, Translarna may be good for a BMD patients bearing a nonsense mutation. So why is that? Because there may be an exon skipping that does not happen within the transcript as a whole. So there may be a part which does not produce dystrophin. So Translarna may help this transcript region to produce more dystrophin. This may be the case. Anyway, when a drug is approved, this means that there are clinical data behind the application for that approval. And it seems like so far there's no much evidence about the benefit of this drug to be prescribed and to be reimbursed, by the way. So this is part of the drugs that have not been approved yet and can therefore be prescribed to early access schemes patients, but that is not always the case and should not always be the case. Of course, there are differences between BMD and DMD. We know BMD natural history less well than we do DMD, and because it is milder, it is actually more difficult to have a deep understanding, but it's something that we might want to actually deepen in the near future. Thank you very much, by the way. Thank you, Dr. Bello, for being with us via the phone. I'd like to recall, as you said, that Translarna or Ataluren, or whatever we want to call it, is a product that has been approved in Europe, and it can now be used also for over 2-year-olds. For that, the pharmaceutical company has also activated a compassionate use that may include reimbursement. So thank you. And now question number 3. By the way, since Dr. Bello mentioned BMD, tomorrow morning there will be a session totally dedicated to BMD. Now, this question is by Walter, and the question is the following. Exon 45 skipping is okay with the 45 deletion, or else, which is the exon to be skipped when there is a 45 exon deletion? I don't know, maybe Dr. Ferlini will want to take the floor here. Well, I may take the floor, but I believe Luca or Luigi may also want to come into play. So this is quite a well-known misunderstanding. Actually, when we talk about exon skipping techniques, we never consider the skipping of the deleted region. This is something that I believe should be recalled, and it's something that we can remember easily. So when we say exon 45 skipping, it never concerns the patients with an exon 45 deletion. I mean, I can understand it may not sound that nice, but that's how it goes. And I think it's quite clear and simple. However, there are some deletion intervals that may be eligible to different exon skipping, different exon numbers skipping techniques. And these intervals are multiple intervals. I just can't recap them all right now, but they can be seen in several pharma companies' websites or other websites, so that you can check whether your son has a given deletion, which is the possibly best exon skipping technique whereby he is eligible to that. For example, for 45 exon, the 44 exon skipping technique is the most frequent one in DMD patients. But now, of course, if the other colleagues wish to take the floor here, they're welcome. Well, I believe Professor Ferlinghi has said it all in a very, good and clear way. So I have nothing to add. Well, actually, it's easy to remember it like that. This is what I always say to the families. An exon deletion precisely rules out the exon skipping which orbits around that given exon.
Andiamo con la prossima domanda.
Next question.
Allora, è una domanda molto interessante che pone Alberto.
The question is from Alberto. It is a subject that has been discussed, combined therapy, gene therapy and exon skipping. Could they be complementary therapy for patients such as his son? The son is 4 years of age. He's eligible for exon 50 skipping. He'd like to know whether combined therapies are a possibility in the future. Anyone?
Comincio sempre io.
Well, I am the one who's supposed to start that. To break the ice, I don't know whether I am only partially a medical geneticist, but there are some bases, there are some papers that have been published, and maybe Luca and the other colleagues can add something to what I say. They have shown that combined approaches can be extremely promising. So a pre-treatment with antisense, there are a couple of papers on that, on animals, but we're still speaking of preclinical trials. So there are, and they can then facilitate gene therapy. So there is the possibility of combined therapy, considering these approaches. I'd say that combined therapies are extremely interesting. Let's consider what Giulio Cossu told us today. I didn't know about this approach, but he told us about this mix between cell therapy and antisense and using the cells as a vector. I mean, it is one of the most elegant examples to speak about combined therapy, antisense and gene therapy, cell therapy and exon skipping. The human imagination is great to try and find solutions to something that is as complicated as the therapy for DMD. So a very general comment. May I add something? We all agree that combined therapy tomorrow will be more effective than 2 separate therapies. The problem is that a clinical trial is extremely complicated. So the number of variables that must be assessed, patient selection, randomization, and also the difficulty for neuromuscular diseases to have clear outcomes. Well, in patients where you have a problem with hemoglobin, there you just measure hemoglobin and you know if the therapy is working or not. Whereas in our case, outcome measures are very complicated. There are individual variations, especially children may respond in different ways. So adding 2 variables simultaneously would be great, wonderful, but it might create confusion until you don't have a clear response for each of the two therapies. Of course, on mice, you can do whatever you want because that gives you an initial indication, but then bringing this to a clinical trial is really very complicated, even though I believe that in the future that will be the solution. One general consideration on combined therapies. I agree with Professor Koss. It is extremely difficult to collect evidence for combined therapies. The trials are already very complicated, and they would become even more complicated. Registries will become very important. Observational studies where each patient is followed by a reference center, and then you can have a systematic data collection. So you have the story of each patient, and so you can have scientific evidence from registries. And then combining gene therapy and exon skipping, beware, don't skip an exon of the mini gene, because if we skip an exon of a normal dystrophin, we can destroy that dystrophin because you have the normal transcript out of frame. If we do the 51 exon skipping in a normal person, of course, that would create damage. That shouldn't happen with microdystrophin because all designed microdystrophin just jump exon 51. Exon 51, for example, is never contained in micro dystrophin being used for gene therapy. But that is something to be taken into account as to the feasibility of these studies in the future. Just one comment. I agree. Of course, I am speaking in theory. As to Luca's comment, I was speaking about a pre-treatment with antisense, not simultaneous. Some British groups. So co-treatment is one thing. So working with two drugs at the same time. Whereas the combined may use different time windows. You don't have to do it that simultaneously. That was a pre-treatment with antisense to restore some functions of the sarcolemma and then facilitates the effect of gene therapy. Just a point of clarification, but of course I agree with you.
And if I may make a point, great discussion, as Dr. Ferlini and Dr. Bella said. I do believe there's an opportunity to use both therapies, perhaps before, but also if you take an example from another neuromuscular disease, SMA. There, if you look at the patient population, a lot of people that are on gene therapy are now subsequently also getting treated with the exon skipping modality. So there are opportunities to combine the two. There's places for each of them individually as well. But perhaps if the therapy durability is not there, we could add on exon skipping. So there are multiple options that should be available for patients.
Ottima discussione, ottime osservazioni.
Excellent discussion and excellent observations. And we have another question. Marco has a son who is 8. Is a DMD boy with stop mutation in exon 64. He is treated with cortisone and ataluren. The question is there any other trial in Italy for the same mutation? Since it is a nonsense mutation, I try to answer. I don't know if there is something I'm not aware of, but the therapy is doing corresponds to the standard of care we have at the moment. And no, I'm not aware of any enrollment in Italy for trials for nonsense mutations. But of course, if anyone else has different pieces of information, please do come in. No, I don't think so. we can say that all patients who take Translarna commercially, they can be included in a data collection in phase 4 studies. So the enrollment is over, so maybe it can no longer be included, no longer be enrolled now because it's over, the enrollment is over. Thank you. Next question, Ilaria. Riccardo has a question for Dr. Piccaro. When Sarepta envisages starting the clinical phase of exon 52, amenable to exon 52. It is a difficult question. I'll try and answer in a simple way. 52 is the one that is the first in line after those already approved, even though it is in a preclinical phase. How much time it takes from the preclinical phase to the clinical phase depends on a number of variables. Sometimes they are understandable, other times they're not. Apart animal studies, the results also from the viewpoint of toxicology, I mean, what you can obtain in animals, that is the precondition to understand if a drug can be used in men. But there is something even simpler than that. Sarepta works very, very hard in this sector, but of course, as many other biotech companies, we must also consider the available resources. So this is a project that has just been started, and I don't know the time frame. It is the most advanced in the group of those that are least developed. Well, that might mean that since we have completed the first 3 PMOs, maybe this is the next one, but I won't be able to give you a precise time frame. But I mean, we are committed to it and the project is underway. Thank you, Luigi. A father asks us as ATPMO 51, Sarepta is considering trials in Italy, and if so, when? Well, hello, Costantino. Well, yes, can you answer in the Q&A now? Well, in Italy should be included in the second part of the trial, so not so much the one for the maximum tolerated dose, but rather the one of dose expansion. So we should include Italy among participating countries. The regulatory process is underway, and we do hope we can start in the next months. There again, I mean, I realize there is this expectation to have set dates, but there are many variables. I can only say that Italy is one of the countries where we are going to carry out the second part of this trial. Great expectations. And as I keep telling you, well, as soon as possible, of course, we can inform the families through news on our site. And this is the reason why every day we get up and start working. Thank you. Thank you. And we'll share the news. Well, this is a small scoop in a way because, patients that have this exon 51 are still have an unsatisfied need for many years now. we have a BMD patient, age 50, and is asking what therapies for nonsense mutations. Well, that is something we have already mentioned. At present, it is impossible to prescribe Translarna to Becker patients because the indication says DMD, because there is no evidence on the risk-benefit ratio. So at present, the specific therapy cannot be prescribed for nonsense mutation. So the standard care, so with no pharmacological therapies, glucocorticoids are not used with BMD unless in very, very specific conditions or during adolescence, and just support therapy, as we'll be hearing in the BMD session. We hope future studies, not only for nonsense mutations, but for all BMD patients. Thank you. Well, yes, tomorrow we'll be speaking about strategies for BMD, not specifically for nonsense mutations, but of course, now we can move to the next question. I believe this is the last one. And Alberto again.
Una domanda molto bella, molto interessante da un punto di vista del fenotipo.
So this is a very interesting question. In terms of the mutation phenotype, are there any prediction models about the DMD development, the DMD evolution? Maybe Dr. Ferliti would like to answer. Well, I'm not sure I understand the question. Let me try and interpret the question. So the idea is, are there any phenotype prediction models based on mutations? Can we interpret the question like this? Apparently that is the case. Therefore, this is what we mean by phenotype-genotype correlation. And the answer is both easy and difficult, easy and complex, because, you know, the frame rule is still there. It is an important rule that we comply with whenever we have to identify deletions, and it is a rule to be used for all mutations, somehow changing the reading frame apart from duplications. So apart from duplications, any other mutations modifying, thus interrupting the reading frame, well, for these mutations, the prediction is no dystrophin and therefore a more severe phenotype, that is DMD. Otherwise, the opposite applies. This is a rule, you know, it's a well-established rule in our clinical practice. However, it is not applicable to all mutations. I already mentioned the duplications. They do not fall within this framework because they account for very complicated genome complexes, and therefore they're out of it. The rule shall not apply there. And small mutations are also out of this framework. So basically, for predicting the clinical phenotype, we do have some margins. We do have some room for maneuver, but not for all mutations. Plus, there are the exceptions. We don't really know why they occur. There are some in-frame mutations that still show some severe phenotypes, for example. So we'll probably have to better define our spectrum. Of course, several reports already include such a more in-depth definition of the spectrum. But as we often say, it is by the follow-up that we can truly say the kind of development that regards that particular boy. So we don't have a 100% prediction model. It is based on genotypes, and there's no certainty about it. I don't know if I've answered the question. Thank you. Well, yes, I think you have. I believe you have. But there's another question by Mario. He has a son, 12 years old, with an exon 66 deletion. So what about the future possible therapy here? Well, it's me again. Again, if I understand the question well, there may be a frame shift mutation there. Well, frame shift mutations are the ones for which there's no approved medicine. It's not, the conventional AON that can be used. Therefore, these are the kind of patients who may actually be eligible for gene therapies whenever they are available. But please feel free to comment. Anybody else? Well, in the meantime, that's quite a clear answer. I understand there are no more questions. Therefore, let me once again stress the relevance of the registry. And we know that this registry is constantly updated. This has particularly been the case in these past 2 years. We've even changed our platform. So we are now in the process of checking all data all over again. In the meantime, even clinicians have been welcome to register, providing their data. Patients themselves will be included, possibly in association with their own clinicians. You can understand how long this will all take. Hopefully you will forgive us if we won't make it too soon, but we really want to have everybody on board. And again, it is incumbent, you should sign in. If you can't do so, just contact us and we'll try to help you out. Having said that, I believe we can close our morning session. Thank you very much. Enjoy your lunch and see you back here at 3. Some music, especially for the younger ones in our public. But of course, further to that, other scientific and psychosocial sessions will follow. Thank you again. I'd like to warmly thank all the speakers. They have been very clear, extremely willing to participate in the Q&A session. And thanks also to all those who have asked those questions. Thank you. See you later. Bye.